Unit 2 Health Planning Steps. The first one, analysis of situation. First you have to analyze population, mortality, morbidity and manpower. And second one, establishment of objective and goals. So we have to reduce the prevalence. And third one, assessment of resources. You have to assess manpower, money and material. And fourth one, fixing priorities, which one is needed, treatment or vaccination for disease. And write a formulated plan, so it should be input and output. And sixth one, programming and implementation. So whatever we are planning, we have to implement. And seventh one, we have to monitor whether the planning has been appropriate or not. And eighth one, we have to evaluate. Evaluate is the appropriate things. And next one, 5-year plan. So in the previous topic in the unit 1 itself, we had discussed the 12 5-year plan. So that same 5-year plans you can write it. So that is from the development of community health history. So you can write first, second, third, fourth up to 12th 5-year plan. Next we move on to the third topic. So the third topic is the health planning committee. The first one is the BORE committee. They are focusing on the PHC. Population covers 40,000 and the medical officer, the staffing 2 and public health nurse 4 and then 1 nurse and 4 midwives are there. And second one, Mudaliar committee, 1962, strengthen the PHC and improve the quality. So this is the objectives. And Chada committee, implementation of National Malaria Eradication Program. And next one, Mukherjee committee, so separate staff for the family planning program, so you should not give any other work to them. And fifth one, Jangalwala committee, so according to Jangalwala, unified cadre, so all the members are uniform cadre. And no private practice, that is the government doctors should not have their own clinics and equal to all. And then common seniority should be allotted according to this Jangalwala committee. Next one, Qatar Singh committee. So in this, in the place of ANM, the name has been changed to the female health workers. And in the place of malaria surveillance, the person name has been changed to male health workers. And next one, Srivats committee. So develop referral services and establish medical and health education. And next one, Ramalingeshwara committee. So here 30 bed hospitals has been allotted for every 1 lakh population. And next one, Bajaj committee, 1986. The vocational course in paramedical science has been started. Ninth one, Krishnan committee, 1992. So here we are focusing on the motivation for family planning. And next, 10th one, Rural Health Scheme, 1977. So here we are giving the training to the community health workers. The next topic, stakeholder. So in community health nursing, it includes patients, public healthcare professionals, that is nurse, doctors, and then community leaders, and then local and government health agencies, and then non-governmental organization and health insurance. So these groups all have your interest in the community health and can either be a recipient or influencer of health services. For example, the first one is the public and then patients. So here, individual and communities who use the health services and are directly affected by the health outcomes. So the patient. And second one, healthcare professionals, already you know. So the community health nurse, physician, pharmacist and specialist. And next one, community leaders and organization. So these are individual and groups who have influence within the community. For example, leaders, that is community leaders, faith-based leaders, and then local community groups or association. And fourth one, government and policy makers. So here, local, state, national, and then government bodies that funds and they will regulate and set some of the policies for the healthcare, such as the health department and some of the elected officials. So patient, professionals, leaders and policymakers. And next one, health system and administration. So this includes hospital and clinic administrator, some of the governing board and other institutions. And non-governmental organization, NGO. So these are private organization and they will provide health related services and they will give support, or often they will focus on the specific health issues or the population. And then insurer or payer. So health insurance companies and other entities that pay for health services are also the stockholder. And last one, educator and researchers, like schools and universities that train the future healthcare workers and they conduct the researches, so that will impact on the health practices and policies. So overall, health system and administrator, NGOs, non-governmental, insurer, payer, educator and researcher. Next, move on to the definition. It implies the organization, delivery, staffing, regulation and quality control of healthcare services. So this is according to J.E. Park. And move on to the objectives. First one, to improve the health status of population, and second one, we have to improve the experience of care, and then to reduce the economic burden, to improve the social justice, equality. Next, move on to the characteristic. The first one, orientation towards the health, and second one, population perspective, and third one, intensive use of information, and fourth one, focus on the consumer, and next one, the knowledge of treatment outcome, then constrained resources, coordination of resources, and then reconsideration of human values, and then expectations of accountability, and then growing interdependence. So now this is the main important. The organization is divided into central level, state level, district level. So each one will be discussing in detail. So you have central, state, district level. The first one is the central level. So you have three divisions: Ministry of Health and Family Welfare, then Central Council of Health, then Director General of Health Services. So under Union Ministry of Health and Family, you have Department of Health and Department of Family Welfare. So under Department of Health, you have Secretary, Joint Secretary, Deputy Secretary and Administrative Staff. And Department of Family Welfare, you have Secretary, Additional Secretary, Commissioner and then Joint Secretary. So this is about the Union Ministry of Health and Family Welfare. You have Department of Health and Department of Family Welfare. So the functions are divided into two forms according to the responsibility. So one is the union list and another one is the concurrent list. First we move on to the union list. This is the first one is the international health relation and administration of port quarantine, and second one, administration of central institute, and third one, promotion of research. How we will promote the research? Through the research center. So if you see oncology and all, so many researches are going on. And next one, regulation and development of medical, pharmaceutical, dental and nursing professions. And last one, establish and maintenance of drug standards. So this is about the union list. Next one, census collection and publication of other statistical data, and then immigration, and then regulation of labor in the working field, and then we have to coordinate with the states and other ministries. Next, move on to the concurrent list. So first one, you have to prevent all the extensions of communicable disease, and second one, you have to prevent the food adulteration, and third one, we have to control of drugs and poison and vital statistics, so that means birth, death, everything, and then labor welfare, then economic and social planning, and last one, population control and family planning. So this is the main functions of the concurrent list. So prevention, communicable, food adulteration, control drugs, vital statistics, labor welfare, economic and social planning, population control and family planning. Central Council of Health. It was set up by the Presidential Orders on 9th August 1952. So under the Article 263 of the Indian Constitution. Okay, who is the chairman? The Union Health Minister. Who are all the members? The State Health Minister. Next, move on to the functions. So the first one, we have to consider and recommend board outline of the policies. So the first one is policy making. And second one, make proposal legislation in the field of medical and public health. And third one, recommendations regarding distributions of available aids and mainly for the health purposes. And next one, establish organization to maintain cooperations between the central and then state health department. So this is about the function of Central Council of Health. And next one, Director General of Health Services, so DGHS. So under this you have Deputy DGS Medical Care, and then Public Health, and then General Administration. So this DGHS Medical Care is divided into Nursing Advisor and then Deputy Nursing Advisor. Okay, next move on to the functions. What are the main functions? General: survey, planning, coordination, programming, appraisal of all the health matters. And if you move on to the specific, so you'll have international health relation and control of drug standards, medical store departs, and postgraduate training like PG training, medical education, research, and central government health schemes, and the national health programs will be conducted, Central Health Education Bureau, and then health intelligence, and then National Medical Library maintenance will be taken place in the specific aspect function of Director General of Health Services. Next, move to the state level. State Ministry of Health, State Health Directorate. So under this division, Health Secretary, you have Additional Secretary, Deputy Secretary, and then Administrative Staff. So this comes under the State Ministry of Health. So you have Additional, Deputy, Administrative Staff. Next, move on to the function. Assisting the ministers in policy making, and then formulating, review, modifications of broad policies, and then executions of policies, and then we have to coordinate with the Government of India and other state members, and control for smooth and efficient functioning. So now the State Health Directorate is divided into functional, regional, additional directorate. So you have functional deputy, then regional deputy director, and then additional directors. Next, move on to the function. So first one, provide adequate medical care, and second one, medical education and research, and next one, national health program implementation, and then provisions for health scheme. So continue with that. Food and Drug Administration control, collection of health information, and control over ESI scheme, and then enforcement of professional standards. So first one, medical care, research, then health programs and health schemes, then drug administration control, health information, ESI, and professional standards. The next, third one, district level, you have subdivision, tahsil, community development block, municipality corporation, and then village level and panchayat. So if you see the urban area district, so you'll be having a corporation, municipal board, town area committee. Function of municipal board. So what are the functions they will do? Construction and maintenance of road, then sanitation and drainage, and then street lighting, and then public health, and then maintenance of hospital and dispensaries, and then educations, and then registration of birth and death. Okay, next move on to the Panchayat Raj. So under Panchayat Raj you have Panchayat, Panchayat Samiti, Zilla Parishad. So under Panchayat you have Gram Sabha, Gram Panchayat. So this question is very important. Next one, primary health care in India. So you have village level, sub-center level, primary health center, community health center. First move on to the village level. The first one is the village health guide. So it has been started in 1977. Now it has been replaced by the ASHA workers. The next one, training of local guides. So it has been started under rural health scheme, and the training of local guides for 13 days, and now not preferred. So this is not preferred. And next move on to the ASHA. So admit under the NRHM for every 1,000 population. And then you have the important link between the community and then health services. And next one, AWW. So this is under ICDS, and this is appointed for every 400 to 800 population. So this is about the village level. The next one, primary health center. The concept of PHC was given by the board committee, and one PHC for every 30,000 population in plain area, and then 20,000 in the hilly area. And what are all the functions? The first one, medical care. Second one, MCH, family planning. Third one, safe water supply and basic sanitation. Fourth one, prevention and control of disease. And fifth one, collection and reporting of vital statistics. Sixth one, education about the health. And seventh one, national health program involvement. And eighth one, training of the health workers. So medical care we are giving, maternal child health, family planning, basic safe water, basic sanitation, control of disease, vital statistics, birth, death registration, and educating about the health programs training. The next one, you can able to see the staffing pattern of PHC, medical officer, accountant, pharmacist, and how many members they are needed. So everything they have been given. So type A and type B, and type A essential 13 and 18, and type B 14, 21. You can have a look on that. And next one, community health center. The block is a unit of rural planning, and the development it comprises of 80,000 to 1.2 lakh population. And one community health center is being established in each block. And if you see, the office in charge of community health center is superintendent CHC, and then normal one CSF should have. Function of community health center. So the care of routine and emergency 24 hours delivery services, essential emergency obstetrics care, and then full range of family planning services, safe abortion services, and then newborn care, routine and emergency care of sick children, removal of the foreign bodies and all, and then tracheostomy, implementations of national health programs. So this is the main function of community health center. So emergency they will give, 24 hours care they will give, and then emergency obstetric care and family planning services, safe abortion, newborn care, and then sick children they will take care, tracheostomy, removal of foreign bodies, and then implementation of national health program. The next topic is National Rural Health Mission, NRHM. So it has been launched 5th April 2005 for the period of 7 years. So 5 to 12. And 2017 again extensions has been taken care. And then the main thing, improve the rural health care delivery system and operations in the whole country. And they're focused 18 state, 8 empowered action group state, and then 8 northeast state, and then Himachal Pradesh, even Jammu and Kashmir. The aim is provide accessible, affordable, accountable, effective, and reliable primary health care, and then to bridge the gap in rural health care through the creation of ASHA workers. So NRHM launched 5th April. Plan of action to strengthen the infrastructure. First one, creation ASHA, strengthening sub-center, strengthening PHC and community health center. First, creation of ASHA. Who is ASHA? Accredited social health actives. And then the selection, who will select? Resident of the village, the woman married, widow, divorced, preferably 25 to 45 years. And then formal education up to 8th class. And then communication and leadership quality should be there. One ASHA, they will cover 1,000 population. So they mostly focus on the tribal hilly areas, and one ASHA for the habitation. Plan of action. So ASHA role and responsibilities, you can able to see promote construction of household toilets, work with village health and sanitation committee, and inform about the birth, death, disease to PHC subcenter. And C is the counseling to women, and M mobilize to pregnant women and children to PHC subcenter. P provide primary health care, and D depot holders. A awareness of the health determinants. You can see the integrated role of ASHA with Anganwadi. So they will organizing health day at AWC, and IEC activity they will take those days, and then updating the list of eligible couple, and mobilizing pregnant and lactating women and infant for nutrition supplement. What is the main thing of ASHA? Organization of the health and nutritional day. And A&M act as a resource person, so you can discuss about the problem faced by A&M and motivate the people and distribute the to attend the outreach sections and motivate the pregnant women for ANC and distribute the oral pills and look for danger signs of any pregnancy. So this is about the integrated role of ASHA with Anganwadi workers and A&Ms. So the ASHA role and responsibility is very important. So you can get for 5-mark question. The next one, strengthening the sub-center. So supply of essential drugs, both allopathic and Ayush, and provisions of multipurpose workers, additional A&Ms wherever needed, and sanction of new sub-centers and upgrading existing sub-centers, and then provisions of funds 10,000 per annum in all 18 states. And how will strengthen the PHC? The main aim is quality, preventive, promotive, curative, supervisory, and outreach services, and then adequate and regular supply of essential drugs and equipment for PHC. So what are the syringes for immunization, and then provisions of 24-hour services, at least 50% PHC by including Ayush practitioners. So this is including in all the PHC center, and following standard treatment guidelines, and then upgradations of 24-hour referral services, strengthening the communicable disease. Strengthening community health center for first referral, so existing of 30 to 50 beds as 24 hours first referral units, so including posting of the anesthetist. And so in this 30 to 50 bed hospital will be there, 24-hour services, anesthetist will be available, and then maintain Indian public health standards and setting up of norms for infrastructure, staff, equipment management, and they'll promote Ragi Kalyan Samhita for the hospital management, and then developing standards of services and cost in the hospital care. And proposed NRHM infrastructure, you have the block cluster of GPS PHC level, gram panchayat sub-center level, village level, ASHA and other members will be available. Next, move on to the National Urban Health Mission. So aim to improve the health status of the urban poor, especially the slum areas, and then migrant, homeless, rag pickers, and then rickshaw pullers and other vulnerable groups. Next, move on to the objectives. The first one, ensure the equitable access to quality primary health care for the urban poor, and then we have to reduce the mortality and morbidity among the vulnerable urban population. Then strengthen primary health care infrastructure in cities, then improve outreach, community participation and health awareness, and then provide affordable, accessible and available accountable services. So the NUHM mostly focus on the urban population. So objective, equitable access, reduce mortality morbidity, strengthen PHC infrastructure, improve outreach and provide accessible accountable services. Next is the target population, urban poor living in the slum, homeless population, and then street children, migrant construction of workers, rag pickers, rickshaw pullers, vendors, and then elderly, disabled, women, children in the urban poor areas. The key strategies: infrastructure strengthening, urban primary health center UPHC, one for 50,000 population, urban community health center for referral services, then mobile medical units MMU for outreach in undeserved areas, and then urban health and wellness center for comprehensive primary care. So this is about the infrastructure. Next one, human resources, the medical officer, staff nurse, pharmacist, lab technician, A&M in the urban, ASHA, urban social health activist, and one ASHA for 1,000 to 2,500 population. This is about the human resources. Next, community processes, Mahila Arogya Summit, 10 to 12 women groups in slums, and promote awareness, hygiene, sanitation, reproductive and child health. And next one, public-private partnership, engagement with NGOs and then private hospitals and charity organization. Then urban health planning, city and ward level health planning, and then mapping of slums and vulnerable group. So C is community processes, public-private partnership, urban health planning. Services provided under NUHM. First one, preventive services, health education, immunization, vector control, and water sanitation support. So each topic you have to go in very detail and you have to explain immunization schedules, everything, how do you control the vector, and water and sanitation support, everything. And promotive services la nutrition, counseling, adolescent health awareness, and then family planning. So this is about the services provided under NUHM. Next one, curative services, OPD services at UPHC, and then basic diagnostic studies, and then treatment of minor illness, and referrals of UCHC district hospital. And then reproductive, maternal, newborn, child and adolescent health, ANC, PNC, and natal, postnatal, institutional delivery referrals, newborn care, growth monitoring. If they are asking in very detail, you can go in very detail of each. Antenatal means what, postnatal means what, how they are doing the institutional delivery, so not in the home delivery, everything you can explain in detail. Newborn care, growth monitoring. Communicable and non-communicable disease, TB, malaria, dengue screening, hypertension, diabetes screening at health centers, and then urban ASHA. And this is the role and responsibility. Household visit, mobilizing for immunization, and ANC, supporting family planning, health education, linking community with the UPHC, and maintaining all the records. The next one, Mahila Arogya Samitam. So the women's groups for community mobilization and promotes hygiene and health awareness, and then utilizes United Funds for small health related needs. And eighth one, funding pattern. So how the center and the state they are giving it the ratio, 75:25 ratio, 90:10 for any and special category state. Monitoring and evaluation, HMIS reporting, UPHC and ASHA performance indicator, and then urban health scorecard. And 10th one, achievement, expanded primary health infrastructure in urban area, and improving the access to the RMNCH plus A services, and then increased community involvement through the MAS and ASHA, and better health services reach to migrant and slum population. The next one, challenges, higher urban migration, overcrowding and poor sanitation, and limited space for health facility constructions, and then inadequate community participation in some areas, and then human resource shortage. So these are all the challenges they are going to commit, and they have to going to solve this problem. High urban migration, so overcrowding, poor sanitation, limited space for health facilities, so they are planning for good constructions, and then inadequate community participation in some areas, for example cancer and HIV AIDS and so on, all they are not at all involving, and human resources shortage. The next one, National Health Protection Mission, NHPM. Okay, so this is launched in 2018 under Ayushman Bharat, is one of the world's largest government funded health insurance programs. So this is nothing but the health insurance given by the government. It aims to provide financial protection and equitable access. So you can able to see the dark word, so that is very important. So this is the main key point, you can note this one. 2. Quality healthcare for the poor and vulnerable families in India. Objectives of NHPM, so reduce the out-of-pocket expenditure for hospital care, and then provide cashless and paperless treatment to the beneficiary. And third one, improve the access to the secondary and tertiary level healthcare. And then fourth one, you have to strengthen the universal health coverage, UHC. And fifth one, promote equity by targeting deprived rural and urban poor families, so focusing on the rural and urban poor families. Sixth one, improve health outcomes through yearly treatment and reduce the financial burden. So the main objectives, reduce out of packet expenditure, then this is a cashless, paperless. Secondary, tertiary treatment they are giving, they are covering universal health coverage, equity and health outcomes they are focusing. Some of the key features, provide 5 lakhs per family per year for hospitalization, and then covers secondary tertiary care, that is pre and post hospitalization, and then portable access India, and benefits can be availed in any embedded hospital, any type of hospital, and rural restrictions on family size may be 5, 6, 7, 10 in age or gender, and covers pre-existing disease from day one itself, and empanel both the public and private hospital, and this is based on the socio-economic and caste census, SECC. Next, move on to the component of Ayushman Bharat. The first one, Health and Wellness Center, HWCS. So here we are giving the primary care and provide comprehensive primary health care screening program. They are doing MCH care and NCD management and basic diagnostics they are undertaking, and act as first contact care at the community level. And second one, Pradhan Mantri Jan Arogya Yojana. So this is the insurance scheme, provides financial risk protection for serious illness and they are requiring the hospitalization. Next, move on to the eligibility. Rural families as per SECC, landless household person, and the families with no adult learning members are there, and then scheduled caste holders, SC members, and kacha house, manual laborers. And if you see the urban families, 11 defined occupational categories already they mentioned. For example, street vendors, domestic workers, laborers, etc. So those rural and urban families are covered under this. Services covered under this: medical, surgical package, all medical condition and any surgery if you want to undergo. And then oncology, that means cancer, cardiology, nephrology, nephro means the kidney, orthopedic bone conditions, anything, and ICU care, and then day care treatment, and then follow-up care, and then pre and post hospitalization expenses. So they are covering up to 15 days. So this is about the services covered under this. Implementation mechanism, National Health Authority. So this policy and override, and then state health agencies implementations at the state level, and then empaneled healthcare providers, so hospital delivering the services, and then Ayushman Mitras, so help desk will be available in the hospital for patient assistance, and IT platform, so this is the digital ID, and then e-card, online claim processing will be taken part in this implementation mechanism. So NHA, SHA, EHCP, Ayushman Mitra, IT platform. Role of NHPM in community health. First, we have to reduce the catastrophic health expenditure among the poor people. So we have to give an awareness. And second one, we have to increase institutional care, and then we have to reduce the morbidity and mortalities, that is the disease conditions and the death rate. And then promote health seeking behavior in marginalized communities. And next one, we have to support the yearly diagnosis to the health wellness centers, and we have to improve the continuum of care from primary to the tertiary level. So you all know primary, tertiary already I have discussed, and strengthen the public health system through the demands for the quality services. Next one, what are all the advantage? Enhance affordability and accessibility of healthcare, and we have to encourage the public-private partnership, and then we have to reduce the health inequity, and then we have to provide financial security for vulnerable households, and then we have to improve quality of care due to the standard treatment guidelines. So what are all the challenges? Low awareness among the beneficiaries, so we have to give more awareness, and then inadequate infrastructure in the rural areas, and then shortage of trained health personnel, so trained person has to be trained properly. Difficulty in identify the eligible couples, so many rules and regulations they are given under the urban, so that and all we have to identify. And delay in hospital reimbursement, and then overcrowding in empaneled hospitals. So these are all the disadvantages there. So we have to take challenge and overcome this in order to implement this program. Finally, we are seeing the conclusion. This National Health Protection Mission, so this is the key point for the universal health coverage, and then providing a sustainable financial cover, and also improving the accessibility to quality health care, and then it significantly strengthens the community health, especially for the poor and vulnerable. And then this is very effective implementation, so we have to increase the awareness and strong primary health care will further enhance this impact. So everyone should know about this, and we have to give health education to the community people to utilize this insurance cover given by the government. The next topic is mid-level healthcare provider, MLHP. So this is a health professional who has received specialized training in order to deliver the essential primary healthcare services. So their function has the first point of contact at the community level. So they are direct contact with the community person and then bridge the gap between the community and higher level health facilities in India. So these MLHP are posted primarily at HWCS, that is Health and Wellness Center, under Ayushman Bharat program. So what is the reason? To strengthen the primary health care delivery. So this is about the introduction about the MLHP. So when you are writing like this, it will add up your points like introduction, conclusions. Okay, MLHP is a trained health professional, often BSc nursing graduate or a community health officer. So they will deliver the comprehensive primary health care that includes preventive, promotive, curative and basic emergency services under a defined scope of practice. So this is the definition of MLHP. Objectives: to ensure accessible, affordable and quality primary health care. And second one, we have to provide comprehensive healthcare services that is close to the community. And third one, we have to reduce the burden on secondary and tertiary healthcare facilities. And fourth one, we have to improve the health indicators by promoting the early detection and timely referrals. Referrals means, so we have to refer the patients from sub-center to PHC to the tertiary level hospital. And fifth one, to enhance the community participation in health promotion activities. So ensure, provide, reduce, improve, enhance. So this is the main objectives of MLHP. So what is the role? The first one is the clinical role, assessment and diagnosis of common diseases. And second one, we have to manage the minor elements like fever, diarrhea, minor injuries. And we have to follow the care for chronic diseases like diabetes, hypertension and asthma. And basic emergency care and first aid treatment we have to give under the clinical role. The next one, public health roles, health promotion and prevention activities, and then community health assessment and surveillance, and then nutritional counseling and maternal child health services, then school health activities and health education campaign. And when you move to the MCH, antenatal care, so you have to identify the risk, and then postnatal care and newborn assessment, then immunization services, then family planning, counseling, and then insertions of IUCD, intrauterine device, and follow-up services. So these are all the main role of public health role, MCH services. And follow that, communicable disease control, screening and early detection of disease like TB, malaria, HIV, and then implementation of national health programs. And then we have to contact the tracing and reporting. And fifth one, non-communicable disease management. So we have to screen hypertension, diabetes, cancer, and then lifestyle modification counseling. And then we have to monitor medication, their effects, side effects, everything. The next one, administrative and managerial role. So maintaining records and reports, then inventory management of drugs, supplies and equipment, and then coordinating with ASHA, ANMs and other health workers. And finally, enhancing the functions of health and wellness center, that is HWCS. Scope of practice of MLHP. So mainly comprehensive primary health care. So the first one, MCH service, and second one, family planning, and then reproductive health, and then care for communicable, non-communicable disease, and basic ophthalmic, ENT and oral health services they can give, and then mental health support and counseling, and then emergency stabilization and referral services. So under MLHPS, they are providing comprehensive primary health care. So these are all the main components they are focusing by the MLHP members. The next one, competencies required, clinical assessment and decision making skill they should have, and then good communication and counseling skills. Then they should have the leadership and then team coordination and knowledge about the national health programs like HIV/AIDS, National AIDS Day and World Health Day, like that. And then emergency care and referral management they should know, and data management and digital health literacy they should understand. So this is about the skills they have required. The next one, advantage of MLHP in health system. First, they are strengthening primary health care and they are reducing the patient load at hospital. And second one, they are improving the accessibility in rural and underserved region. And then they are enhancing early diagnosis and they are reducing the complication. And then this is cost effective method of expanding the health workforce. And they are increasing the community trust and then engagement. So these are all the advantage of MLHP in health team. So strengthen, improve, enhance, cost effective and increase the community trust. So challenges faced, heavy workload due to the multiple responsibilities, and they have inadequate infrastructure or resources at a health wellness center, and they have limited clinical authority when compared to the doctors, and the need for continuous training and supportive supervision, and then cultural and social barriers will be there in the community they have to accept. So these are all the challenges they are faced by the MLHP person. Last one, the conclusion. So MLHP they are placing the pivotal role in strengthening Indians primary healthcare system, and they are the backbone of a health and wellness center, and they're ensuring delivery of comprehensive and then quality health services they are providing at the grassroots level with the proper support, training, resources. So this MLHP can significantly we can improve the health outcome, and they are contributing to achieving the universal health coverage. So this is about the conclusions of MLHP. So this is very important questions you can expect in the university question. Ayushman Bharat is a flagship health initiative. This is launched by the Government of India 2018 to achieve universal health coverage, and the main aim strengthen the primary health care and provide financial protection against the catastrophic health expenditure. So many money we are spending against that, so they are protecting us, especially for the poor and vulnerable people, and they are mainly focusing promotive, preventive, curative, rehabilitative and palliative care. Next one, component of Ayush Bharat, you have two component. One is the health and wellness center. This is launched to strengthen the primary health care. The main objectives are provide accessible, affordable, comprehensive primary health care. And second one, we have to reduce the burden on secondary and then tertiary healthcare facilities. And third one, we have to improve the early detections and management of disease process. Services are under HWCS. You have 12 comprehensive health services. The one is MCH, second one reproductive health, and third one neonatal and infant health. Then fourth one is a communicable disease, and fifth one is a non-communicable disease, and sixth one mental health care, then elderly and palliative care, then dental ophthalmic care, emergency services, health promotion and wellness activities. Next one, basic laboratory services, and 12th one, free essential drugs and diagnostic. And if you move on to the workforce, the first one who are all involving community health officer, second one ANM, and third one multipurpose health workers, then ASHA workers. These four members are involving. And second component, Pradhan Mantri Jan Arogya Yojana. So the world's largest government funded health insurance scheme. So under this they are providing 5 lakhs health insurance. They are covering per family per year, and they are covering poor and vulnerable families identified through the SECC data. There is no cap on the family size, age or gender, and cashless, paperless treatment in Empowered Hospital, and it covers secondary and tertiary hospitalization. So what are the benefits covered? Hospitalization expenses, pre-post hospitalization, daycare procedure, cancer care, and then cardiovascular surgeries, ortho, urology, nephrology, pediatric and other services. And mostly they are focusing on the medicine, diagnostic, implants and ICU care. Then the implementation structure: National Health Authority NHA, national level; state health agencies SHA, state level; and empowered public and private hospitals. So these are all the implementation structure. And objectives: reduce out of pocket expenditure, and then ensure health equity, then strengthening the primary and secondary care, and then improve the accessibility of healthcare services, then protect family, that is the poor families, from catastrophic health expenditure, and then achieve the universal health coverage. So these are all the objectives of Ayushman Bharat. The next one, advantage: financial protection for poor and vulnerable group, and access to quality healthcare, and then strengthen the primary healthcare through the HWACS and reduce the economic burden due to illness. And then we have to increase the utilizations of health services, and we have to promote preventive and promotive healthcare service. Challenges: shortage of trained health workforce, limited infrastructure in rural area, delayed reimbursement to hospital, and then awareness issues among beneficiaries is low, and overburdened tertiary care centers, and need for stronger digital health system. The last one, the role of nurse: the screening, the non-communicable disease, MCH healthcare, and then health assessment and the first level management. We have to provide health education, promotion, and counseling, then maintaining records and digital data entry, and then coordinating referrals, then supporting community health officers in HWCS, and patient care in PMJ empowered hospitals. So these are all the role of nurse. So under conclusion, this is a transformative health program aimed for strengthening India's healthcare system to the comprehensive primary care and financial protection for health hospital care, and it plays a crucial role in reducing the health inequalities and moving the country towards the universal health coverage. And in this, the nurses forms an essential role in implementations at all the levels. So this is about the conclusions about the Ayushman Bharat. So this is very important question. So I gave for 15 mark question. You can get for 5 mark question. So you can simplify with this topic. If they are if you want to give more explanation, you can give under the topic. The next topic, National Health Policy 2017. So this is the third major health policy of India. So after 1983, 2002. So what is the main aim? Achieve the highest possible level of health and well-being for all the age groups. So mainly focusing preventive, promotive, curative, palliative, rehabilitative services. And what all the focuses? Affordable, accessible, and then quality health care. So this is based on universal health coverage. So this is about the introductions about the National Health Policy 2017. The next one, vision: attainment of the highest possible level of health and well-being through a preventive, promotive, healthcare orientation in all the developmental policies. Okay, next focus on the goals. The first one, we have to reduce MMR to less than 100 per lakh live birth, and reduce IMR to 28 per thousand live birth, and reduce NMR to 16 per thousand, and stillbirth to 16 per thousand. And we have to achieve TB elimination by 2025, and we have to reduce the premature mortality from NCDs by 25% by the year of 2025, and increases the life expectancy up to 70 years. The next one, system strengthening goal: we have to increase the health expenditure 2.5 to GDP, and we have to increase the government health spending to 70% of total, and then we have to ensure availability of free drugs and diagnostic at all public health facilities, and then we have to strengthen health information system. Next one, key principle: equity and affordability, then patient-centered care, then quality of care standards, then digital health technology, gender sensitivity, and then skill development of health workforce. Major strategies: the first one, preventive and promotive health care. The first focus on the changes in the communication, school health promotion, then Clean India mission, then safe water sanitation, control of tobacco, alcohol and lifestyle disease. And second one, universal health coverage. So we have to reduce the out of packet expenditure, provide free essential medicine and diagnostic services. Then financial protection through government schemes. Third one, health infrastructure strengthening, transform sub-center to health and wellness center, then improve PHC, CHC and district hospital, and then upgrade trauma center and emergency care system. And fourth one, human resource development. You have to increase the training institution, address shortage of doctors, nurses, ANM, and then introduce mid-level health providers, that is MLHP at HWCS, Health Wellness Centers. So, health infrastructure, human resource development. Fifth one, quality of healthcare, implementation of national quality assurance standards, and then patient safety guidelines, then ICT based monitoring. And sixth one, affordable healthcare, price control on essential medicine, promote generic drugs. And next one, expand the insurance coverage for mostly poor and vulnerable persons. Seventh one, digital health initiatives, that is e-health record, telemedicine, national health information network. And eighth one, public private partnership. So here we are focusing on the diagnostic, ambulance services and then specialized services. Then partnership for training and capacity building. Innovation under NHP 2017. So Ayushman Bharat 2018. So here focusing on the health and wellness center and PMJ 5 lakhs health insurance and use of AI and mobile health apps, and then focusing on the palliative and rehabilitative services. Under achievement, rapid expansion of HWCS across the India. Second one, decrease in MMR and IMR. Then increase availability of free drugs and diagnostic in many states, and then strengthening of digital health platforms, mostly telemedicine. Last one, conclusions under NHP 2017 is a comprehensive policy more focusing on universal access, equity and quality care, and also focusing heavily on the preventive health care and then digital transformation and financial protection for the population. Then the policy act as a foundation for achieving universal health coverage. The next one, sustainable developmental goal. You can able to see the 17 pictures. So each one will explain in details. So no poverty, and then hunger, good health and well-being, quality education, gender equity, clean water, and then automobiles. So many 17 points with the pictures you have under the global goals for sustainable developmental. So each one will explain and will discuss how to present these conditions. The next one, sustainable developmental goal. So this is set up of 17 global goals, and it is adopted by the UN General Assembly in the year of 2015. So under this 2030 agenda. So what is the main aim? To end the poverty and protect the planet and ensure peace and prosperity by the end of 2030. So they are the universal, integrated, and then it is interdependent. There are 17 sustainable developmental goals. The goal 1, no poverty. So end poverty in all forms everywhere. And goal 2, zero hunger. So end hunger, so achieve food security, and we have to improve the nutrition and promote the sustainable agriculture. And goal 3, good health and well-being. So ensure healthy lives, and then reduce the maternal and child mortality and fight against the diseases and ensure the UHC. And then the goal 4, quality education. So inclusions, equitable education for all the members. Goal 4, quality education, inclusive and equitable education for all the members. Goal 5, gender equality, So end the discriminations and empower the women and girls. And goal 6, clean water and sanitation, safe drinking water, sanitation, hygiene for all. And goal 7, affordable and clean energy, so access to renewable reliable energy. And goal 8, decent work and economic growth, so productive employment, safe water environment. Goal 9, industry innovations and infrastructure, promote the sustainable industry and innovation. Goal 10, reduce inequalities, reduce inequality within and among the countries. And goal 11, sustainable cities and communities, you have the safe, resilient, inclusive urban areas. And goal 12, responsible consumptions and production, so we have to reduce the waste and promote the sustainability. Goal 13, climate action, so combat climate change and its impact. And 14, life below water, so protect the marine ecosystem. And 15, life on land, protect forest, biodiversity and ecosystem. 16, peace, justice and strong institution, promote peaceful societies and then provide justice for all. And 17, partnership for the goal, strengthen global partnership for sustainable development. Next, move on to the importance. So this influence health outcomes, especially SDG 3. So the nurses contribute in reducing maternal and child mortality, and then promoting hygiene and sanitation, then health education and disease prevention, nutrition counseling, community participation, environmental protection activities. And then this gives a guide planning and implementations of community health programs. The next one, key features, time frame 2015 to 2030, and universal, applies to all countries. And then integrated, social, economic, environmental focus, measurable target 169 target and 232 indicators. And then people centered and planet centered. Conclusion, SDGs provides a comprehensive roadmap for global development, and then achieving SDGs requires some of the active participation from government, health workers, communities and individuals. And nurses plays a crucial role in achieving health related SDG through the promotive, preventive, curative and rehabilitative care.